Can you hear me? Sudhir?
We can hear you. I think only the Guru Vandana we didn't hear this.
That's good actually. We couldn't hear the Guru Vandana. Very good evening to all of you. I am Dr. Richa Kothari from the Indian Association of Cardiac Imaging. And today we'll continue with our ongoing physics webinar session. Today is our sixth talk on post-contrast cardiac MRI, perfusion, nulling and beyond. The speaker for today is Dr. Pudyavan. I welcome Dr. Pudyavan. He is a cardiothoracic radiologist at KMCH in Coimbatore. And he has been one of the main speakers of our ongoing physics webinar series. The session will be moderated by Dr. Sanjaya Vishwamitra. He is the chairman of our Indian Association of Cardiac Imaging and head of department at Satya Sai in Bangalore. Welcome, sir. Without much ado, I'll hand over the dais to Pudyavan to start his talk.
Thank you, Richa. Just share my screen. So, okay. So, I welcome you all to the sixth session of this IACA Physics webinar series. We've been having a wonderful series so far. We've had some expert opinions, talks from stalwarts in the field. So to continue the series, so today's talk will be on post-contrast CMR, perfusion, nulling and beyond. So we'll be focusing on the post-contrast sequences, which are the most important sequences in cardiac MR. So the objectives of this talk will be to look at what are the commonest post-contrast sequences that we use, the basic physics behind these sequences, and a little bit about how to get good quality images using these sequences. So a small recap of the sequences used in cardiac MR. So we have already seen the basic sequences, the black blood, the white blood sequences, the cine, double and triple inversion recovery sequences. We had a wonderful talk on flow and phase contrast imaging by Dr. Rajesh sir. And we also talked about K-space, which was a pretty difficult topic, which Sanjay sir did an excellent job. So now what we are going to do is we're going to see these three sequences, mainly the dynamic perfusion sequence, the delayed enhancement sequences, and a little bit about contrast enhanced MR angiography. The T1, T2, T2 star mapping techniques. So we will be covering these advanced sequences in our next talk. So before I go into the post-contrast sequences, a little bit about the contrast agent that we use for cardiac MR. So we use a gadolinium-based contrast agent in a dose of around 0.1 to 0.2 millimole per kilogram. So the recommended dose is 0.1 millimole per kilogram for cardiac MR applications, though some studies have gone up to 0.2 millimole per kilogram. As you all know, there are two types of gadolinium-based contrast agents, linear and macrocyclic agents, and these can be either ionic or non-ionic contrasts. Coming to these two contrast agents, the macrocyclic gadolinium contrast is considered to be a safer contrast, especially in patients with deranged renal function, because it has a stronger bond with gadolinium, and the rate of gadolinium deposition and the risk of NSF is considered to be smaller with macrocyclic agents compared to linear agents. But whereas image quality is considered, I did try to do a lot of literature search for this talk, and there is no clear-cut recommendation for which contrast agent is better for cardiac MR applications, whether linear or macrocyclic. Though the T1 relaxivity values of some of the linear compounds are much higher compared to the macrocyclic compounds, though in clinical practice there have been no clear recommendation for using either. So it's up to the your center's finances and the patient's characteristics that you can either choose to use a linear or a macrocyclic gadolinium contrast agent. So coming to the hardware that is needed for doing a contrast study, if you're doing only viability studies, then a hand injection is more than sufficient, because we are not worried about the first pass perfusion or the contrast dynamics. So we are more inclined to see the delayed enhancement of the myocardium. So a hand injection will be more than enough for viability studies alone. However, if you're planning on doing myocardial perfusion studies, then a pressure head injector, a dual head pressure injector is preferable to deliver a uniform rate of contrast. When you're doing perfusion studies, the rate of injection has to be kept a bit higher, maybe around 4 to 5 ml per minute, and always lesser lesser contrast with 0.5 millimole per ml compounds is preferred over a 1 millimole compound. So gadobutrol is one MR contrast agent which is available as a 1 millimole per ml concentration. You can use it, especially for viability studies. It might not make much of a difference, but I will come to that why we prefer a 0.5 millimole agent compared to a 1 millimole agent when we are talking about darkroom artifacts in the perfusion studies. Coming to dynamic perfusion imaging. So what is dynamic perfusion imaging? So this is a sequence that is done to assess myocardial perfusion. So what we do here is we use a gadolinium based contrast agent, which has T1 shortening properties and increases the signal intensity of tissues, which can be helpful to assess the myocardial perfusion. So in this sequence, we usually do imaging at 3 levels: the basal, mid, and apical cavity. And all these 3 images has to be acquired within a single cardiac cycle. So the reason that we stick to just 3 levels and not cover the entire LV cavity with multiple levels is mainly the because of the consideration that the number of good quality images that can be obtained in a single cardiac cycle. So when the cardiac cycle is shorter, it is very difficult to get good quality images with good SNR within a single cardiac cycle. So we usually limit to 3 levels, that is in the basal, mid, and apical cavity. And these 3 levels will be able to, with these 3 levels, we will be able to assess 16 segments of the 17 segment model in the heart. So as you can see in this diagrammatic representation, so that is, we take a short run of pre-contrast, short pre-contrast run, then the contrast is injected, and then the contrast enters the right ventricle, then the left ventricle, then there is perfusion of the myocardium, and finally there is washout of contrast from the myocardium. So this is the contrast kinetics that happens when we inject contrast agent into the patient. Coming to the sequence per se, so what is expected of an ideal sequence for doing a dynamic perfusion imaging? So first and foremost is that we need a single shot imaging technique that provides image in a single cardiac cycle. So perfusion imaging is time sensitive. So what we are doing here is we are assessing the first pass perfusion of the myocardium. So we can't use a multi-shot technique which acquires images over multiple cardiac cycles. This is because there is a rapid change in the image contrast when the contrast passes through the LV cavity to the coronaries and into the myocardium. So when we start imaging over multiple cardiac cycles, then there is a mixed image contrast image that we obtain, which might not be helpful for us. So we need a single shot technique which can provide an image in a single cardiac cycle. Second, we'll need to use a sequence that has very good T1 weightage. This is to maximize the effect of gadolinium contrast on the image contrast. So gadolinium has T1 shortening properties. So to utilize that, we need a sequence that that has a very good T1 weightage. There are 2 important things to be considered. One is the spatial resolution and the temporal resolution. So spatial resolution is nothing but the ability to differentiate an enhancing and a poorly enhancing area in the myocardium. So we need good spatial resolution. However, there is a caveat that the spatial resolution is limited by the heart rate and is inversely proportional, whereas the temporal resolution is the ability to acquire image in every cardiac cycle. So when the heart rate is high, the cardiac cycle becomes shorter and there is very little time for us to acquire the images, and hence the spatial resolution of the image is compromised in this scenario. Coming to 1.5 Tesla versus a 3 Tesla system, dynamic perfusion imaging is much better in a 3 Tesla system. This is because of the higher field strength and gradient strength, which makes it, which recruits a lot of protons in the patient's body, thus increasing the signal to noise ratio. So coming to the sequence per se, we use a gradient echo sequence which uses a short TR and a small flip angle. But the problem with using a short TR and a small flip angle is that there is not, when we are trying to image, get 3 images in a single cardiac cycle, is that there is not enough time for the decay of the transverse magnetization that happens because of the radio frequency pulse. So this is overcome in different ways by different sequences. The first and foremost is the spoiled fast gradient echo sequence, which uses spoiler gradients to destroy the remnant transverse magnetization before the next RF pulse. So in this particular sequence is relatively slower compared to the other sequences. However, it is less prone to artifacts. Coming to the next sequence that is used for dynamic perfusion, it is the steady state free precision or the SSFP sequence. So here the transverse magnetization is brought back into phase after successive RF signals. So we give additional balancing gradients and bring the transverse magnetization back into phase so that it provides a better signal to noise ratio and a contrast to noise ratio. However, the flip angle that is used in an SSFP sequence is a bit higher, and hence the imaging time as well as the artifact occurrence is much more higher with the SSFP sequence. And the third sequence is the echoplanar imaging or the EPI sequence. So here we use an alternating frequency encoding gradient, which is interspersed with few phase encoding pulses. So here the entire K space is filled with a single echo train. So an radio frequency pulse is given and it is followed by alternating frequency encoding gradients, which produces multiple echoes, and a large echo train is produced by this sequence. So the drawback of this technique is that it is much faster, but the drawback is that because of the long echo train, there is a lot of T2 star decay that happens in this sequence. So what we finally start doing is that, so here as we can see, the SSFP sequence has the best signal to noise ratio. However, it is prone to artifacts, whereas the hybrid EPI technique, which I will just talk to you in the next slide, which is a slight modification of the EPI technique that we just saw, has better speed, and it is also a better compromise between signal and artifacts. So coming to the hybrid EPI, so it is similar to EPI technique where we use a rapidly alternating frequency encoding gradient, which are interspersed with phase encoding pulses. But instead of using a long echo train, what we do here is that we segment the EPI pulse into multiple RF pulses with pre-saturation pulses, so that the echo train is kept to a manageable level. So in this example, you can see there are 5 echoes that are produced for each RF pulse. So this here, the echo train length is 5. And as you can see, as the time progresses, the intensity of the echoes also becomes smaller and smaller. And this is because of the T2 star decay. So what we do is we don't let T2 star decay take over the image quality. So we segment the sequence into multiple segments with shorter echo train lengths. So by doing this, this becomes a faster sequence and is less prone to artifacts. And hence the hybrid EPI or the segmented EPI is the most commonly used sequence for perfusion imaging. So this is an example of a hybrid EPI perfusion image. So this is acquired at 3 levels. the basal cavity, the mid cavity, and the apical cavity. And as you can see, the images are obtained in every cardiac cycle so that you are able to follow the passage of contrast into the right ventricle to the left ventricle and starting to perfuse the myocardium. And you can also see the perfusion defects in the lateral wall. So here, the T1 weightage of the image is controlled by something called as saturation time of the preparatory pulse. So the saturation time is nothing but the time gap between the preparatory pulse that is given at the start of the cardiac cycle and the RF pulse that is given. So the time gap between the RF pulse and the preparatory saturation pulse is called the saturation time. And this saturation time determines the T1 weightage of the image. So if you give a longer saturation time, the T1 weightage will be more, and the shorter saturation time means T1 weightage will be less. But you cannot increase the saturation time beyond a certain limit, because you'll have to obtain 3 images in a single cardiac cycle. So that we have to arrive at a compromise where we use something called as the P reduction factor, which is nothing but we select a P reduction factor or the highest saturation time for a given heart rate. So if the heart rate is 60, so we select the highest saturation time, which gives the most T1 weightage, and at the same time, which will also allow us to acquire 3 images in a single cardiac cycle. So coming to the assessment of perfusion images, so the assessment can be either qualitative or quantitative. So qualitative is nothing but the visual analysis of perfusion, visual analysis for perfusion defects in the T1 weighted images. So in this image, you can see that we visually see and determine that there is a perfusion defect in the lateral segments in the mid cavity. So when you are doing a visual perfusion analysis, then you have to give contrast, gadolinium contrast at a dose of around 0.1 millimole per kilogram. So there is another way of doing the perfusion analysis, which is the quantitative analysis, which is the estimation of the myocardial blood flow using the arterial input function. So the problem with doing a quantitative analysis with the arterial input function, especially with gadolinium contrast, is that there is a peculiar phenomenon that happens with gadolinium. Normally, we will assume that when the concentration of gadolinium increases, the signal intensity of the image will also increase. So this is an understanding that we all assume that the higher the gadolinium contrast concentration, higher will be the signal intensity. However, there is something called as a non-linearity effect that happens with gadolinium contrast, where beyond a certain point in the concentration of gadolinium, further increase in the concentration of gadolinium will not cause an increase in signal intensity. So this is called the non-linearity effect. So a higher concentration of gadolinium beyond a certain point will not cause an increase in signal intensity. So this becomes a problem because during the arterial input function, so the gadolinium contrast is injected, so the signal intensity rises to a peak, and then there is washout of contrast and an equilibrium phase is obtained. But the arterial input function, that is the first pass perfusion of the gadolinium contrast through the LV, the signal intensity is not directly proportional to the concentration of gadolinium that reaches the LV cavity. So this results in a spurious estimation of myocardial blood flow if we are using the arterial input function to quantify the perfusion. So to overcome this, what we can do is we can use a lower concentration of gadolinium so that the gadolinium concentration remains in the part of the curve where there is a linear relation between concentration and signal intensity. However, if you want to use a lower concentration, then you have to use a concentration of around 0.01 millimole per kilogram for quantitative assessment. But when you use such a low concentration of gadolinium, what happens is that the image has a very poor SNR and contrast to noise ratio, and the background noise is too high, and it poses a significant problem when doing quantitative evaluation. So to summarize, we often don't use quantitative analysis for myocardial perfusion imaging, and we mostly rely on qualitative analysis because of this drawback that the quantitative estimation of myocardial blood flow has. Coming to another drawback of doing the myocardial perfusion imaging, which is the dark rim artifacts. So these dark rim artifacts manifest as a transient signal void in the endocardial boundary, and it can be easily mistaken for subendocardial perfusion defect. So here you can see this, there is a thin line of subendocardial low intensity region, which is a dark rim artifact and not a perfusion defect. Whereas you can see a perfusion defect in the septum very clearly here, whereas the low intensity area that you're seeing in the inferior and the lateral wall is a dark rim artifact. There are certain ways of differentiating a dark rim artifact from a true perfusion defect. One is that typically a dark rim artifact will only last for a few heartbeats, especially when the contrast concentration is very high in the LV cavity. And the other thing is that the intensity, the signal intensity in the area of dark rim artifact can go below the baseline, that is below the value of pre-contrast signal value, whereas a true perfusion defect will never go below the pre-contrast value. There are various reasons that are attributed to the dark rim artifact. One is because of truncation effects, because of high frequency sampling that happens at the interface between a higher and a lower intensity signal area. It can also be due to susceptibility effects because the gadolinium is a strongly paramagnetic substance which causes significant T1 shortening, and a higher concentration of gadolinium in the LV cavity because of its susceptibility effects can also cause these dark rim artifacts. And motion, breathing as well as cardiac motion can also result in these dark rim artifacts. And these dark rim artifacts are worse at stronger concentration of the contrast agent. So there are certain ways to reduce these artifacts. One is by using parallel imaging techniques. Avoid using SSFP sequence because they are more prone to susceptibility effects, and reduce the contrast concentration. So that's why I told you that it is better to use a 0.5 millimole contrast agent over a 1 millimole contrast agent, especially when you're doing a perfusion imaging. So that's about the myocardial perfusion imaging. Next, we will move on to the delayed enhancement. So delayed enhancement, you all know it's the most important sequence in cardiac MR. So delayed enhancement is based on the fact that the T1 values of the myocardium changes dynamically after contrast injection. So you all know that the T1 values of myocardium will vary depending on whether the myocardium is normal, whether it is scarred, or whether it is blood. But the problem is that the differences in T1 values in baseline, that is before contrast injection, between a normal myocardium and a scarred myocardium and an area of microvascular obstruction is very minimal, and it's very difficult to differentiate them. So this is overcome by the fact that after injection of contrast, the T1 shortening that happens in the normal myocardium, scar, and the MVO accentuates the differences in T1 values between these tissues, and this also changes over time. So this is based on the fact that during the baseline, that there is a difference in T1 values between a normal myocardium, blood, and scar. However, this difference is not that great. However, when we inject contrast, there is an arterial input peak, then the recirculation of gadolinium happens, and then equilibrium phase is reached, at which point the difference in T1 between these tissues is more pronounced. And we exploit this phenomenon using delayed enhancement sequences. So coming to delayed enhancement sequence per se, so here we use a multi-shot technique. We don't use a single shot technique because the delayed enhancement is not time sensitive. The perfusion image is time sensitive because there is a rapid change in contrast of the image because of the first pass perfusion. And so we needed to get images very fast. However, in delayed enhancement, the contrast is already in its equilibrium phase. So we know there is no time concern for us. So we can go ahead and do a multi-shot technique over multiple cardiac cycles to get an image which has a better spatial resolution, and we are not much worried about the temporal resolution of the image. So here what we use is again a fast gradient echo sequence, but with an inversion pulse. So here there is an inversion, 180-degree inversion pulse, which is followed by a readout gradient. And the time gap between the 180-degree inversion pulse and the readout RF pulse is the inversion time. So this inversion time is given so that the signal from the normal myocardium is nulled, so that the abnormal myocardium or the scarred myocardium is seen much better. So what we basically do here is that the gadolinium accumulation there will be in the myocardium, and in the equilibrium phase there will be slow washout of gadolinium from the myocardium. So in a normal myocardium, this washout is much faster, whereas in a scarred myocardium, which has a lot of extracellular space to accommodate a lot of gadolinium contrast within it, the washout is not that much faster. So the T1 shortening is much more pronounced in areas of scars compared to the normal myocardium. And we use, on top of this, we use an inversion pulse so that the signal from the normal myocardium is completely nulled, so that the contrast between the normal myocardium and the abnormal scarred myocardium is much bigger, and we are able to differentiate these two much better by using an inversion recovery based fast gradient echo sequence. So selecting an appropriate TI time at which the normal myocardium nulls is very important in a delayed enhancement sequence. So this TI time is not a constant. So this will change from patient to patient, and a lot of factors determine the TI time. One is the hemodynamics of the patient, and the TI time also has a tendency to progressively increase over time after contrast injection. So there are two types of delayed enhancement that we can do using the inversion recovery fast gradient echo sequence. One is the early gadolinium enhancement and the late gadolinium enhancement. So the early gadolinium enhancement is a sequence that is done at around 3 to 5 minutes post contrast injection, and this is not done in all patients. It has certain specific scenarios where we will be doing early gadolinium enhancement sequence, and this is done mainly to assess the capillary leakage and microcirculatory disturbance. So this is mainly used to look at areas of microvascular obstruction in the myocardium and to differentiate thrombus from an infarcted myocardium. And it can also be used in cases of myocarditis. Here, what we do is we use a fixed constant long TI of around 440 milliseconds at 1.5 Tesla and around 600 milliseconds at 3 Tesla. So the reason that we use a long TI for early gadolinium enhancement is that, as you can see in this recovery image, so during the early gadolinium enhancement phase, what happens is that at a long TI, there is a greater contrast between the normal myocardium, scarred myocardium, and the areas of microvascular obstruction. But since this is an inversion recovery sequence, the routine IR sequence cannot differentiate the polarity. So when you use a TI time, which actually nulls the normal myocardium, what happens is that there is a lot of overlap of signal intensities which happens at the particular TI time during the early gadolinium enhancement. So this is the reason that we use a longer TI when we are using an early gadolinium enhancement sequence, so that the differentiation between the areas of MVO, normal myocardium, and scar is much more pronounced, and there is not much of mixing of signal intensities when there is a early gadolinium enhancement. Whereas in late gadolinium enhancement, we do the imaging at around 10 to 15 minutes post contrast injection. And unlike the early gadolinium enhancement, where we use a fixed long TI time, in late gadolinium enhancement, the sequence is mainly to assess myocardial fibrosis and scarring. And our main aim is to differentiate normal myocardium from scarred myocardium. So here we use an individually tailored TI time. So a particular TI time is selected that nulls the signal from the normal myocardium and maximizes the contrast between normal myocardium and the scar tissue. So in this image, this is a late gadolinium enhancement image. You can see that the normal myocardium is completely nulled with black signal, and there is a greater contrast between the area of scar and the normal myocardium. So TI scout or TI readout is something that is designed to find the optimum inversion time to null the normal myocardium. So this is again an inversion recovery sequence, similar to the delayed enhancement sequences, but here we use incremental, it's a single shot technique with incremental TIs. So we do an inversion recovery sequence, but instead of a single TI time, we repeat the sequence with multiple TI times, usually from around 150 to around 550 milliseconds in a 1.5 Tesla system, and a little bit higher for a 3 Tesla system. So by doing this, what we achieve is that we achieve a set of images with different TI times. And while doing a TI scout, we encounter something called as the TFE factor, which is nothing but increases the number of readouts per RR interval. So if you have a lower heart rate, you can have more readouts per RR interval than when you have a higher heart rate. So this reduces the scan duration. So increase the TFE factor when your heart rate is low, and your scan duration will come down. So this is a typical TI readout. So you have multiple images with different TI inversion times. So in this image, what you are going to do is you are going to select an image where the normal myocardium is nulled, meaning that the signal from the normal myocardium is black, and there is greatest contrast between the LV cavity and the normal myocardium. And as you can see in this chart, with increasing TI times, the signal intensity of the normal myocardium and the scar also changes. And there is a point at which the signal from the normal myocardium is almost zero, resulting in a black signal from that part of the myocardium. So you select this particular TI time as the inversion time for this particular patient. And you should keep in mind that this TI time will keep on increasing progressively with time, as there is continuous exchange of gadolinium contrast between the intracellular and the extracellular space. So suppose the TI time is around 320 milliseconds at 10 minutes. And if your delayed enhancement sequence is running beyond 15 minutes, then you will have to progressively increase the TI time a little bit so that the normal myocardium is nulled properly. A single slide about PSIR sequence. So the problem with inversion recovery FG sequences is that even a small variation in picking the correct TI time can result in different distributions in the signal intensities of the image. So you will have to be very careful in selecting the TI time for nulling the normal myocardium. So to overcome this difficulty, we use something called as phase-sensitive inversion recovery sequence, which is nothing but a pulse sequence where the image construction takes into account the sign of the Z magnetization at the time of data acquisition. So as you saw, so this is the recovery of the Z magnetization that happens after the inversion pulse. So a PSIR sequence, what it does is that it takes into account both the sign of the Z magnetization, that is the phase of the Z magnetization also. So it doesn't matter whether it is on the negative side or on the positive side. So it can identify the difference between the signal from the positive side and the negative side based on the phase differences. So because of this, the image can be represented on a grayscale on both sides of the Z magnetization. So the normal nulling is kept at 0, whereas the positive side is towards the white of this gray spectrum and the negative side is towards the black of the spectrum. So what happens here is that this increases the dynamic range of the signal. So even though if you don't use the exact correct TI time, just adjusting the window level of the image can give you proper nulling of the normal myocardium. So you have a leverage of around 30 to 40 milliseconds when you are using a PSIR sequence and you are giving a inversion time. So this is the advantage of using a PSIR sequence, that you have a leverage for TI time, and often you can even do away with doing a separate TI scout image when there is lack of time. You can just give standard TI value for your scanner for the given amount of contrast agent, and you can still get good quality images with a PSIR sequence. Coming to optimizing the delayed enhancement sequences. So there is something called as a turbo factor or lines per segment, where it determines the number of lines of K space that is filled in each cardiac cycle. So you can adjust the turbo factor depending on the heart rate. When the heart rate is low, increase the turbo factor so that more lines of K space are filled. Whereas when the heart rate is high, then decrease the turbo factor so that the K space is filled over more heart rates, more cardiac cycles. When the heart rate is high, the small RR interval will not be sufficient to allow the recovery of Z magnetization between pulses, because what we do here is an inversion pulse. So we use an inversion pulse. So we will have to wait for the recovery of Z magnetization. When the heart rate is high, so there is not enough time between two cardiac cycles for the Z magnetization to reverse. So what we can do when the heart rate is high is use pulsing every 2 RR intervals. So instead of imaging every RR interval, we can image at leaving one cardiac cycle in between, so that it gives enough time for the Z magnetization to recover. Second, what we can do is we can use a shorter trigger delay. So trigger delay is the time between the inversion pulse and the start of the RF pulse for signal acquisition. But the problem with shortening the trigger delay is that the trigger delay cannot be shortened less than that of the inversion time. So suppose the inversion time for nulling myocardium is 400 milliseconds, your trigger delay cannot go less than 400 milliseconds. So that is a drawback. So you cannot decrease the trigger delay to very small time. So then you'll have to either do pulsing every 2 RR interval, or you'll have to increase the voxel size so that the scan duration reduces. But this will also cause a poor spatial resolution. Again, when the TI time is high, then they will have to pulse the signal every second RR interval. So all these sequences are, as I told you, are multi-shot techniques which acquires image over multiple cardiac cycles. Hence, breath hold of the patient is very important. And these sequences are very sensitive to the breathing movement artifacts. So if the patient is not able to hold his breath, then you can use a navigator-based free breathing PSIR, where you place a navigator box over the diaphragm on the right side, and this navigator will trigger the scan only when the diaphragm reaches a particular point, usually at end expiration. So whenever the diaphragm reaches end expiration, the scan is triggered and an image is acquired. And when the image is acquired, when the diaphragm is in a different position, then the data for that image is discarded. So this is a navigator-based sequence, which is free breathing sequence. You can also use single shot imaging techniques instead of multi-shot, like what we did for TI scout, where you give a single TI time, but single shot imaging techniques are again very prone to very prone to artifacts because of improper TI time. So your TI time has to be very accurate when you're using single shot imaging techniques. And the downside of single shot techniques is that it has a very poor spatial and contrast resolution. So if you don't have access to a navigator based free breathing delayed enhancement, and the patient is not holding breath at all, then you can go and use a single shot delayed enhancement technique. So coming to the towards the end of the talk, so a little bit about contrast in enhanced MR angiography. So the gadolinium contrast mediated T1 shortening, the gadolinium contrast causes T1 shortening of blood pool. So normally when you see the fat has the lowest T1 relaxation time, and hence it has the brightest signal on an image, whereas the blood is has a much higher T1 relaxation time. So what we do here is we inject gadolinium based contrast agent into the blood, which mixes with the blood and causes a significant shortening of T1 relaxation time of the blood pool. So when there is significant shortening, this produces a high signal intensity in T1 weighted image, and hence we use a spoiled gradient echo sequence to image the vessels. In this sequence, we use a very short TR and TE, as short as the MR system will allow, because the blood is mixed with gadolinium which has a very short T1 relaxation time, and you can get away with using a very short TR and TE and still get high signal intensity in T1 weighted images. The flip angle that is used is mostly in the range of around 30 to 40 degrees. And this range is called the Ernst angle, which is the flip angle that is chosen to maximize the signal for a particular TR and a T1 value. The MR angiography can be triggered by two methods. One is test bolus method or bolus tracking. In test bolus, you just inject a small amount of contrast and run a short spoil gradient echo sequence to determine the time it takes for the gadolinium to reach the heart and start imaging with that time delay when you are giving the actual contrast. Or you can use a bolus tracking method where there is continuous repeated fast acquisition which tracks the gadolinium contrast that is coming into the heart, and you can trigger the scan. The contrast MR angiography with the spoil gradient echo sequence can either be a 2D sequence, or it can also be done with a 3D acquisition by acquiring a voxel data. Just a single slide about time resolved MR angiography. This has been marketed with different names: Trix, Twist, 4D track, depending on the vendor. So what it does is that this is a 3D acquisition with a better temporal resolution. So the better temporal resolution is achieved with the time resolved MR angio by a unique technique by which where there is a difference in the K-space filling of the data that has been acquired. So you all learned that in a K-space, the center of the K-space gives the most of the contrast data, whereas the periphery of the K-space gives the spatial resolution for the image. So in MR angiography, the contrast data is much more important. So what we do is the center of the K-space is more frequently filled compared to the periphery of the K-space. So here you can see that the red is the data that has been filled, goes to the center of the K-space, and the gray is the area, is the data that goes to the periphery of the K-space. And as you can see, the number of red data points are much higher compared to the gray data points. So because of this, the temporal resolution of the image increases manyfold, and you can have a temporal resolution of few seconds because you have contrast data at more frequent intervals compared to the spatial resolution data. So in a time resolved MR angiography, you are able to obtain a temporal resolution of a few seconds compared to around 10 to 15 seconds, which it takes for a routine spoiled fast gradient echo sequence. To conclude, so gadolinium based contrast agents are mainly used for this first pass perfusion as well as for scar identification in late gadolinium enhancement. So dynamic perfusion imaging or myocardial perfusion, we use a single shot technique for better temporal resolution with a slight compromise to on the spatial resolution, whereas delayed enhancement sequences doesn't have any, is not a time sensitive phenomenon. So we can get away with using a multi-shot imaging techniques over multiple cardiac cycles, which gives us a better spatial resolution. And TI time, or the inversion time, is the time that is used to null the normal myocardium. And this will vary from patient to patient depending on the patient hemodynamics. And we can do a TI readout or a TI scout to determine the correct inversion time at which the normal myocardium will be nulled. And contrast enhanced MR angiography is basically used mainly for assessing the extracardiac vascular anatomy, especially in patients of congenital heart diseases. And thank you very much. Thank IACI and for providing me this opportunity, and I thank Sanjay sir also for giving his inputs. And before I hand over to Sanjay sir, I just want to remind you that the 12th annual IACI conference is being planned from 14th to 16th October of this year, and it's going to happen at Bogamala Beach Resort. And this time it will be an on-site conference as well. So I invite everyone to attend this conference. And over to you, sir, for your inputs.
Thank you, Pradeep. I think that's a fantastic lecture again. And it's actually one which one has to listen to a couple of times, maybe to understand all the physics behind it. But again, you need to understand the physics so that you can get the best imaging from it. One of the questions that was asked is, why does darkroom artifact increase with increasing concentration of contrast?
So as I told in the talk, there are a lot of factors that influence these darkroom artifacts. So one is the susceptibility effects, which are more pronounced because of the extreme T1 shortening that the gadolinium contrast agent produces. And with increasing concentration of the gadolinium, there is more T1 shortening, and this causes susceptibility effects at the interface between the LV cavity and the endocardial surface. And this is one of the reasons that is attributed for darkroom artifact, along with the truncation effects because of high frequency sampling. So just decreasing the contrast concentration might not take away the darkroom artifact completely if the artifact is because of some the truncation effects or because of motion. So this is just one step in reducing the darkroom artifact.
So, so Pudi, let's just go over a couple of the points that you made throughout your lectures and just revise some of the highlights of it. So the first one that is important for people to understand is that perfusion imaging is an extremely fast set of images, where, as you mentioned, you are trying to get the highest possible temporal resolution, and you're sacrificing spatial resolution because of that. So one of the things that I see some younger cardiac imagers get confused about is when they're trying to decide whether on perfusion imaging, they can call it as, less than 50%, 25%, and so on and so forth. Whether they try to quantify the extent of perfusion. In your opinion, Pudi, what's the best way of reporting perfusion imaging?
Okay, so we usually don't quantify the perfusion defect in perfusion imaging. We just say the extent of perfusion defect, whether it is subendocardial or a transmural perfusion defect, and we divide the perfusion defects based on the segments. So we don't try to quantify per se. Because quantification becomes a bit difficult, as I told you, because of the non-linearity, and especially when you're trying to calculate the myocardial blood flow values using the perfusion data that you have, then using the contrast doses that we routinely use for visual assessment might not be apt for doing a quantitative analysis. So for doing a quantitative analysis, then we'll have to do the scan in a little bit different way, which might hamper our qualitative analysis of the images. So we prefer doing a qualitative analysis. We don't do a quantitative analysis.
Absolutely. So I think the simplest way of looking at perfusion imaging is there a defect present, or is it absent? If it is present, then you know that that particular region of the myocardium is abnormal. And then you can look at your late gadolinium enhancement images to decide the actual quantity of the murality of the defect can be decided on the late gadolinium enhancement rather than the perfusion imaging. So for those of you who are starting off with perfusion, just to decide whether, as long as it's not an artifact, obviously, if there is a defect or there is no defect and what segments are involved. The second thing that sometimes gets confusing is the concept of early gadolinium enhancement and late gadolinium enhancement. Now, I know that you sort of combine, when you were describing it, you mentioned delayed enhancement as a combination of both, but depending on which articles you read, sometimes delayed enhancement is referred specifically only for late gadolinium enhancement.
Late gadolinium enhancement.
And early gadolinium enhancement can sometimes be referred to as a hyperemia sequence or hyperemic imaging as well. So just be aware that there may be slight differences in terminology, but the most important is late or delayed gadolinium enhancement is typically obtained after 10 minutes, whereas the early gadolinium enhancement is only on very specific indications and is obtained closer to 3 to 5 minutes of time. So Pudi, can you just repeat one more time in terms of optimizing in which conditions do you normally end up doing early gadolinium enhancement? How often do you use it in your routine practice, and in which condition do you specifically look for it?
We usually use it when in scenarios of especially of acute infarction, when we are looking for presence of microvascular obstruction in the myocardium, and also we use it when there is a thrombus in the LV cavity. So for better delineation of the thrombus in LV cavity and for microvascular obstruction. So these are the two scenarios which we most commonly use early GAD enhancement sequences. Early gadolinium enhancement has also been used to detect myocardial edema in myocarditis also, where because of the hyperemia and increased capillary permeability, there is an increase in myocardial enhancement in the early gadolinium enhancement sequences. But personally, I rely more, because I have access to T1 and T2 mapping sequences. I rely more on these mapping techniques in cases of myocarditis than in early gadolinium enhancement. So for me, personally, I use early gadolinium enhancement only in cases of infarction to delineate microvascular obstruction and thrombus.
Right, and I think that's what most people will end up using it as well, simply because it's actually not as simple a sequence as one might think it is. After all, it's just a simple gadolinium enhancement. Why can't you use it in all patients becomes a question. But it's actually a little complicated, simply because, as you mentioned, sometimes you need to pick the right TI time, which is basically a fixed TI time. You can use the fixed TI time approach, or alternatively, the other approach that people have used is the degree of enhancement as compared to skeletal muscle. And if it is 4 times the amount of enhancement that you get with skeletal as compared to skeletal muscle, or 45% increase in enhancement as compared to routine to adjacent areas, then you can call it as hyper enhancing or hyperemic myocardium in that particular region. So the evaluation of the early gadolinium enhancement images also becomes a little complicated when you're looking for hyperemia or for myocarditis, which is why I think the modified Lake-Lewis criteria also has moved away from using EGE and prefers to use mapping sequences, which he will speak about later. So again, just remember that this is, but on the other hand, for microvascular obstruction, you're looking for negative contrast, so it becomes a much easier thing to look for. Thrombus again is negative, you're looking for black areas, so it becomes easier to see, rather than trying to guesstimate as to whether it's really enhancing more than the rest of the myocardium. That is a little tricky. Looking for negative blackness in a particular area is an easier option. So please remember that early gadolinium enhancement is to be used cautiously, and even interpretation is also to be done cautiously and not to be just casually used for everything. So that's something I think people generally sometimes get confused about.
So there are few questions in the Q&A.
Oh, there are. Okay, there are some new questions. Thank you for reminding me about that. Okay, so let me just go over all the questions. Do all scars cause perfusion defects? I guess that's a yes or no question.
Not necessarily. It is not necessary that all scars should cause a perfusion defect. Especially in a chronic infarct, where there is some amount of neovascularization that happens within the fibrotic tissue. A scar in a late gadolinium enhancement might not cause a perfusion defect in a first pass perfusion image. So it is not necessary that all scars should cause a perfusion defect.
But most commonly, Pudi, would you see a perfusion defect, and would you see a concomitant scar on the late gadolinium enhancement as well, for you to be able to call it as a non-viable area?
Yeah, yes, but we usually go with the viability based only on the late gadolinium enhancement images, and I have seen a lot of cases where there is late gadolinium enhancement denoting that it is a scar, but there were no perfusion defects during the first pass perfusion. Especially this happens. This doesn't happen during an acute scenario, but it often happens when there is a chronic infarct with the thinned myocardium. You often see that the scar also enhances well during the first pass perfusion.
Okay. The next question, I think we've already answered. The question is, why is the extent of LGA not the same as the extent of perfusion defect? I think you already answered that when we spoke specifically again to this particular question. Perfusion imaging is either a yes or no phenomenon. You're looking for presence or absence of the presence of a defect or not. Whereas the extent of LGE is much more obvious because it has a higher quantitative, higher spatial resolution, and you can therefore look at the LG spatial resolution is much better. Perfusion imaging is all about temporal resolution and not about spatial resolution. The next question is thrombus and MVO better made out in EGE, early gadolinium enhancement, than late gadolinium enhancement? What is your opinion?
Yes, definitely it is better made out in EGE. This is because in LGE what happens is that we use a TI time that nulls the normal myocardium. So the normal myocardium is also black in late gadolinium enhancement images, and it becomes difficult to differentiate MVO, which is also black, and thrombus, which is also black. So it is much better appreciated in early gadolinium enhancement images than in late gadolinium enhancement images.
The other thing that is that for thrombus, particularly, we have other ways of also trying to evaluate for thrombus. You can use a long TI time.
Long TI, yes. So what happened with increasing TI, the signal intensity of thrombus is consistently low. Whereas if it is something else, or if it is a myocardial tissue, then with increasing TI, the signal intensity of the myocardium will also increase. However, the thrombus signal intensity, even with a very high TI, it will remain dark.
Right. And also remember that thrombus is an intracavitary abnormality, whereas MVO is along the wall of the area. So that can also help you differentiate a thrombus from an MVO. Typically, an MVO is surrounded by an area of infarct, and it also retains its margin with the wall. Thrombus projects into the cavity. The other question, the other comment, I think is a nice comment. It basically is that they use the early gadolinium enhancement for tumors. And I think in my chat box as well, I had mentioned that perfusion imaging can also be used for tumors as well. And maybe you can just add your comment.
Yes, sir. I think I missed out on that point. We do use early gadolinium enhancement to look for vascularity in tumors. And I also find it much more useful than late gadolinium enhancement images, because sometimes what happens is that the TI time that we give for nulling of the normal myocardium can end up nulling the enhancement of the tumor also, especially if the tumor has similar enhancement characteristics as the myocardium. So in these scenarios, it is a little bit tricky to rely only on late gadolinium enhancement images for tumor enhancement. So in these cases, yes, EGE definitely helps rather than LGE.
Right. And I think, so as I mentioned in my chat box as well, the perfusion sequence, right, is you can use the perfusion sequence anywhere in the myocardium. It doesn't have to be at 3 levels. So we use it at 3 levels when we're looking for ischemia, and but if you're looking for tumors, then you put it over the region of the mass, and then you can extend it over 1 minute, 2 minutes if you want, and you can actually see the degree of enhancement over time in a tumor as well. So that becomes another important thing. And I would like to just reinforce what Pudi said just in the last important thing, that remember that when we use late gadolinium enhancement, we are nulling certain areas of myocardium. So it is important that when you use the late gadolinium sequence with a TI time, you realize that you can potentially null any other structure which also enhances similarly to that of the left ventricular myocardium specifically. So if you have a tumor and you're nulling the left ventricular myocardium, you could potentially, as mentioned, end up nulling the tumor as well. So tumor sequences tend to be a little bit modified, a little bit more different from what we tend to use. Similarly, the atrium and the right ventricle can sometimes, and even the papillary muscles can sometimes have slightly different nulling times as compared to the standard left ventricular normal myocardium. And just out of practice, you practice it enough of times and you see the images frequently enough, and you'll be able to figure out how to differentiate all of them from each other. Next question, I think you've already answered very well. Why is MVO and thrombus best appreciated in early gadolinium enhancement sequences. And you mentioned very nicely how you're not nulling the normal myocardium to the same extent. So you're able to appreciate the blackness or the negative contrast of MVO and thrombus better on the early gadolinium enhancement. Last question is, can't MVO and thrombus be missed when we image only 3 slices? So I think the question here about the attendee is perhaps getting confused between early gadolinium enhancement using
perfusion
versus perfusion imaging. Exactly. So could you perhaps just describe what the difference between the number of slices that one gets for perfusion imaging versus EGE?
So, so for myocardial perfusion imaging, where we look at perfusion defects in the myocardium, we use only 3 slices because of the time constraint that we have. So we use one at basal cavity, mid cavity, and apical cavity. But whereas an early gadolinium enhancement sequence is done at around 3 to 5 minutes, and it's done as a multi-shot technique. So we don't have a time constraint there. So it is not, we don't restrict the EGE to only 3 slices. We can do the EGE covering the entire LV myocardium if it is needed. So the 3 slices is only for myocardial perfusion imaging and not for the early gadolinium enhancement images.
Absolutely. So thank you again. We come to the end of our fantastic lecture. You've discussed everything from the beginning of perfusion imaging to early gadolinium enhancement, late gadolinium enhancement, and you've given the audience a lot to think about in terms of how to optimize these sequences as well. And one of the things which I like to mention repeatedly is optimization is not in a textbook. Optimization is all about practice, and you can only optimize something if you are on the scanner and playing around with the sequences that you have on your particular scanner. Please remember that whether it's a GE or a Philips or a Siemens scanner, each one has slightly different ways where they optimize certain things, and you have to get comfortable with your scanner as well. So once again, thank you again, Pudi, for taking us through this excellent lecture on enhancement and use of gadolinium. Richa, back to you.
Thank you, Dr. Pudyavan. Thank you, Dr. Sanjaya, for the brilliant session. Physics being made very practical by both of you so that we can use it in our day-to-day practice and get the best images, because only if we get good images can we report properly on cardiac MR. Next session is going to be the hot topic in cardiac MR. We have T1, T2, parametric mapping sequences. We are going to be covering the physics aspects. Pudi, only the physics, or are you going to cover the clinical bit also?
Yeah, just we will cover the physics and some applied clinical points.
Some applications, right? Okay. So next session is on parametric mapping methods in cardiac MRI, the new hot topic in cardiac MRI. Everyone asks us about that. So it's in July, the 2nd week. We'll be sending you the link as usual. Please do join us for that. Thank you everyone for joining us today. See you in July. Thank you, sir. Thank you, Pudyavan.
Thank you. Thank you, sir.
Session.